Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today's guest is Dr. Skye Zeller. Dr. Zeller grew up in South Florida and moved to New England in 2003 to attend Dartmouth College, where she studied molecular biology. She went on to earn both a master's and PhD in microbiology from Yale University. Following her graduate work, she decided to pursue a career in dentistry and obtained her DDS from UConn in 2018. Dr. Zeller has completed over 300 hours of training on airway health, and in 2023, she became a diplomat of the American Board of Dental Sleep Medicine and a fellow in the Academy of General Dentistry. She's also an instructor with the International Association of Orthodontics in their New England chapter. In addition to that, Dr. Zeller is a wife, a mom to 11-year-old twin boys, and a practice owner. Some of what we discuss on today's show includes what led to Dr. Zeller becoming interested in airway, her comprehensive new patient examination and consultation processes, the importance of getting to know your patient for more than just their teeth, tips on coordinating care with your medical and OMT colleagues, how she handles criticism from colleagues who do not believe that dentists should be involved in airway-focused treatment, how she balances being a wife, mom, busy practice owner, and educator, and much, much more. So without further ado, let's get to my conversation with Dr. Skye Zeller. Enjoy the show, everybody. Welcome to the Doc Podcast, Skye.
Thanks so much for having me.
You're welcome. I'm really excited to talk to you about this. Your name is a name that has come up many times. And prior to us even speaking months ago, many people said to me, do you know Skye Zeller? Do you know Skye? You've got to talk to Skye.
Small circle.
It is. And you certainly have a lot of respect in this arena. And a lot of people look to you for advice and guidance as you've been someone who has really blazed the trail and doing amazing things when it comes to looking to help your patients. And to me, that's what this is all about is, we can debate and discuss how we do it exactly and techniques and timings. And certainly that's part of the fun is to have academic discussions on that. The one thing that I really believe bonds us all together who are on this journey and this path is our desire to help our patients and help our patients be healthy and live better lives. And we're going to talk a lot about that today. So before we do, just tell the audience, if you would, a little bit about your journey, your career. You have a really cool story on how you got in even to dentistry and some of the areas of academia you were in prior to dentistry. So start back as early as you want. And how did you get to be the Dr. Skye you are today?
Sure. So like you said, it's not a traditional journey. I actually fell in love with research science when I was in undergrad. I went to Dartmouth for my undergrad and I joined one of the coolest labs ever, Dr. Dwayne Compton, and he's actually the dean of med school there now.
Oh, cool.
And I just fell in love with the whole atmosphere of research. So leaving Dartmouth, I went to Mass General, did a year of research there and realized that was what I wanted to do with my life. Again, I was 21, 22, so you never know what you really want to do. But I applied to grad school, started a microbiology program at Yale, looking to get my PhD, and really the whole goal was to be a tenure track researcher. That is a long, long road. About 4 years in, I found myself a little bit unhappy with what I was doing. There are aspects of it that I loved. So I love the academic challenge of research. I love thinking through all of those things. I loved using my hands, so I actually loved doing the science. That was one of my favorite parts. But I realized that as I progressed down that career path, I would probably spend more time writing than I would actually doing science. And I felt like there was a disconnect. I spent a lot of time in the basement doing mouse research, and I worked on HIV gene therapy, which is a fascinating topic, but it didn't feel directly applicable to helping people right then and there. And so I wanted something else. And I had met my now husband when I was in grad school. My father-in-law was a dentist for, I think, 35, almost 40 years. And he had tried to get every single one of his kids to go to dental school. Not one of them would go. And so he figured he would try one more time.
Oh, that's so funny.
He brought me into his office. Yeah, kicking and screaming. Dentistry is the dumbest thing I've ever thought of. I would never do that. Wasn't even on my radar. And I watched how he interacted with his patients, how much he cared about every family, the fact that they had started coming to him when they were 3, 4, or 5 years old. And now he was seeing their kids. That was what was missing for me when I shadowed medical doctors, was that connection as well. And so I figured I would just jump on board and apply to dental school.
Wow. And
did
this
a
is
lot
like
of
mid-20s
shadowing.
now you are-ish? Or?
Yeah. Well, yeah, it's got to be late 20s because
Oh,
I
wow.
found out I was pregnant with my twins while I was applying to dental school.
Come on.
Yeah, we tried to plan it. I knew I was going to apply. I wanted to have them before I went so that it wasn't like holding me up. And I remember I was interviewing at NYU and I had just found out it was going to be twins. And I was like, oh, wow, this will be a journey.
Yeah, this is gonna be a hoot. Yeah, wow.
And
Oh,
yeah,
man.
so I was 29 when I had them. Started dental school at UConn a few weeks after that. So they were about 8 weeks old when I started dental school. And went through all of dental school. I love general dentistry. I've always been following what I love, I guess. But I love general dentistry. The idea of being able to do everything was really cool to me. And the idea of being able to pick and choose what I wanted to do was even better. So if I didn't feel like doing something, I could send it out. And if I really wanted to do it and I felt like I could do it as well as a specialist, then I would do it myself. And initially joined a community health center, which was really cool. It was some of the best training I've had because you're seeing everything there. So for general dentistry, it was wonderful. And I met some really great dentists there as well. So some guys who had private practices. I was working a day a week at my father-in-law's practice and working 3 to 4 days a week at the community health center.
Okay.
And we were trying to build a practice for me within his practice, right? But we didn't have enough patients. And so a lot of the private practice dentists who were volunteering were trying to get me to take ortho courses because they were part of this study group that I'm now part of. And they had kept pushing me to do it. And I kept saying like, no, ortho's not for me. You know, I learned about it at UConn. It was pretty much, you have a class 2, extract the upper bis. You have a class 3, extract the lower bis. I didn't feel like extracting anything on kids that, you know, had all their teeth and they weren't a problem. And I just wasn't going to do it. And so I started building this practice out of my father-in-law. And when we didn't have enough general dental patients, I decided I would learn something new because that's how you build a practice. And so I used my continuing education, you know, stipend from Staywell to start taking sleep courses. So the very first courses I took were with Tucker, and it was all about mandibular advancement appliances. So looking at the anatomy of the airway and how can we actually, you know, bring the lower jaw down and forward, open up the airway, create a little more tongue space in the mouth, and help people who can't breathe at night specifically. Okay, so sleep.
Yep.
He said something at that course which was really interesting. And he was like, so how many of you are treating young kids? So I didn't say this, but my father-in-law was way ahead of the game on this. He started doing ortho, I want to say it was back in the 70s, and he was treating kids at age 7, 8, 9, which was unheard of back then.
Yeah.
And so he was constantly trying to be this proponent of this early treatment. So I raised my hand. I'm like so proud of myself. Yeah, in our office, we treat kids by the age of 8. And, you know, Tucker looked at me and he was like, what about by the age of 3? I was like, 3? Come on, you're crazy.
Yeah.
And he was like, 3 years old. He said, you didn't start making an impact at 3 years old. And that wasn't his specialty. And he wasn't about to go down that track with me. But after I said, well, where'd you learn all this? Like, well, tell me more.
Yeah.
And he suggested looking into Healthy Start, which is a company that does a lot of myofunctional orthodontics. Okay. So I did. I sat through a couple courses with them virtually. And then I think it was the Yankee Dental Conference. I went and sat in on that. I started learning about this. And now I'm thinking, okay, I have these 2 5-year-olds at home and all of this pertains to them. Uh-oh, look, what am I doing wrong here? If I'm their mom and I can't even help them, like, what am I doing wrong here? And I guess it was a stroke of luck. But right after that, COVID struck. And I found myself completely unemployed. So Staywell, we got laid off completely and shut down. And obviously, in private practice, there was no there were not enough patients for 2 doctors already, so there were not enough patients for me. And I was not used to sitting around. That didn't do well for me. So between teaching kindergarten and doing a lot of gardening, I started taking all these courses online. And I think in the 2 months that I was laid off, I racked up about 200 hours of continuing education on sleep and airway and breathing.
Wow.
And I was armed and ready to treat my own kids at that point. And so I jumped right in, and my 2 boys were my first patients for expansion. And when I saw the impact that we had on them, I just couldn't stop doing what I do now.
Can you tell me a little more about what was that impact? What did you see with them? What was that like? What were you seeing that concerned you? And then what did you see happen as you started treating them?
Yeah, so it was predominantly one of my kids. So Baxter, he had been hospitalized multiple times for croup.
Okay.
So at that time he was 5, and I would say starting around age 3, which is when kids should outgrow these things, he was getting hospitalized probably every other month and given steroids to try to open up his airway every time he had a little upper respiratory infection.
Wow.
And I had my case control because I had my other son. So you should tell it was normal.
Yeah,
I was like, one of them, the cold hit them both, and one of them was in the middle of the night via ambulance being nebulized so that he could breathe. And it's terrifying.
Built-in concordance study right there. I mean, that's as good as it gets. Yeah.
And so I knew that wasn't right. We talked to the pediatrician about it, and it was like, okay, well, if we have to give steroids one more time, then maybe we'll send to the ENT. And I love our pediatrician. I think he's wonderful. He's very non-alertist, but I was pretty concerned at this point. And so we went to the ENT, and it was like, well, tonsils aren't that big, and adenoids aren't that big, and, you know, if you just have the floppy airway. Well, what do we do with a floppy airway? Well, they'll grow out of it. Okay, but in the meantime, my son's being given steroids almost every month.
Yeah.
And not to mention, you know, I'm frantic in the middle of the night because he's turning blue. And that's very, very, very concerning. I just remember the last straw was when they actually had to admit him because he had multiple rounds of having to be nebulized while we were in the emergency room.
Wow.
And so I started with just the Healthy Start appliances because that's all I knew. I started with a habit corrector, popped them in their mouth, and I said, you guys will wear these to bed, and that is it, right? Okay, whatever, Mom. Like, you know, they're at that age. 3-year-olds, 4-years, 5-year-olds, they want to please you. They're not the 11-year-olds that they are now. They don't care what I see.
Yeah, try to get them to wear it now, right?
Yeah, but back then, they wanted to make me happy. And so they put these things in their mouth, and every night, these appliances fell out of their mouth. Like, well, no one told me what to do now. Why are they falling out? Obviously, because these kids can't breathe. Okay?
Sure.
I started learning more, and now COVID's coming, and I'm terrified that this kid's going to get COVID and not be able to breathe. That was high alert. I put my house on lockdown. No one was allowed in. It's like, you guys don't understand. He gets a cold and we're in the hospital. If this kid gets COVID, like, I won't be able to forgive myself. And so the more I'm learning now online, well, through all these courses that I'm taking, I want to try to expand him. Why not? And so I took him into the office and no one else was there. Took some allogeneic impressions because that's all we had at that point, and sent it off and just got him a simple transverse expander. And I remember I was expanding, and my father-in-law was like, you're crazy, right? The one who was so ahead of the time. He's like, he doesn't need any more space in his mouth. How big are you going to make his mouth? I was like, I'm going to expand him until he can breathe, period. And we did this. And again, that was when he was 5. He's 11. He has not been hospitalized since.
Wow.
He also has not had steroids for croup, I think, one time, and it also took my husband down, whatever that one was. So it was pretty bad. But yeah, so it was a huge change for us. He started sleeping through the night, which was also huge. And yeah, so he was my first case study.
Wow. Really, really cool. Well, thank you for explaining all that. And just to kind of recap, your history really is fascinating. And I appreciate you going through it. And it's neat for people to see that the journey you went on, you obviously are someone who is respected and that knows a lot about this area. And we're going to talk more about that during this episode. The other thing I love to highlight is you didn't always know a lot about this, and you had to go on a journey. And as we'll talk about during today as well, kind of the challenge we face with some of my orthodontic colleagues and getting them to go on this journey. I'm always just encouraging people, just learn more about it. You spent 200 ish hours on CE during the COVID shutdowns to learn. And it was your educational journey. The more you learned, the more you questioned. And that is education to me. That is science to me. This whole just believe it because I said it, or there's this one study out there. I don't follow that school of science. I don't follow that school of thought. I like to challenge things. I like to question things. Yes, you need the fundamentals and the basics and fundamentals of physiology and anatomy and biology. That being said, there's so much we don't know. And there's so much that maybe just hasn't had the right study done. Or maybe it was the right study, but they altered the data, because we all know that happens, right? Or maybe it was
statistics is funny,
right? You can lies, damn lies, and statistics. You can make a lot of things sound pretty good for publication's sake. So, and we not even go down that rabbit hole of the challenges we face with parsing out good from bad science and experiments and studies and literature. The point is, our job, to me, is exactly what you did. And this is as clinicians, as providers, as caregivers, is to always be willing to try to learn. And I think a lot of the trap that my orthodontic colleagues have fallen into, and I say this because I teach a lot of young docs who are so open-minded, and as soon as they start to go on the journey that I take them on and teach, the journey you went on, similar, instantly they're like, yeah, wait, there's something to this. It tends to be the older, more established docs who have been doing it a certain way for a long period of time. And it is really threatening to them to think about the fact that this could be done differently, that this could have been done differently, and that they might have to change the way they think and do everything. That's intimidating. And I get that. I'm actually granting them some grace in that. Like, that's not easy. It's not easy to, you had the benefit, and I don't say this in a way that it was easy at all, just to infer that, but you had the benefit that you had a little bit of downtime with the practice, right? The practice wasn't pumping along and thriving and so busy that you couldn't think. You had to think of ways to try to look to provide a different type of service to your patients. That almost became the key in a lot of this to you being able to go on this journey. Just hearing you and your story, when you're a doc who's seeing 60, 75, 100 patients a day, and your office is running like a machine that seems very well oiled, right? And you have your protocols. If you don't look at kids this young, you don't look at airway, you don't look at, they're this much crowding, you extract teeth, you have your protocols. And it can be really easy to just stay comfortable with that. And then anybody who questions that and says that you could do it differently, you shoot them down and you shoot arrows and you try to shut them up and silence them, because how dare you question the establishment and the way it is. Would you agree with that?
Absolutely. And I'll go further to say that I don't think it's just the orthodontist. I mean, I have a number of friends from dental school or people who know me through different points who will send me in a nice message. It's like, hey, how did you learn how to do this? What course should I take? And I can't respond and say, I think you should spend these 8 hours and only these 8 hours learning everything that I learned. And you can be exactly like me and run your practice the exact same way, because that's not it. It's hard. It takes a huge commitment, and it's time away from your family.
Yeah.
It's making the commitment to be the best or at that level with the best, and giving up everything that doesn't do that for you. So, it's reading papers at night. I did that in grad school. I can do it now. It's just making sure you stay in that rhythm. And if somebody's really interesting and they're holding a course, you make the commitment to go. I flew out to Arizona for 36 hours to learn recently, and then flew back for my nephew's second birthday party that night. There are ways to do it, but you can't just commit to 8 hours of learning on one day and then think that you can do everything. I think the most important part is getting all of the different philosophies, learning from so many different people, and then seeing where your ideas and your personal experience jives with all of that and what you can take from each of those things. My poor hygienist, she's a myofunctional therapist too, so she loves when I do this to her, but I come up with my own theories every day, and I'll just stop her in the middle of the cleaning and be like, Blair, I have a new theory on tongue ties. Or hey, Blair, I was thinking about the effects of cardiovascular health and oral appliance therapy, and this is my new theory on it. And it's not that I have any data to back that. It's that I've read, and this is what I did all through grad school. I've read a lot of research.
Yep.
And now I want to know, how can we take it just a little bit further? Or how does that apply to what I'm seeing, and what theories can I make for these patients. Like, what does that do?
Yeah, that's really how I got to where I got in what I was doing. Was decided I was going to do what you were doing and start to look deeper into the literature. And then also, and it sounds like exactly what you're saying you're doing, looking at the patients and trying to think of more creative ways to solve problems that are more efficient, more effective, and allow you to deliver that care in a superior fashion. And the more you start to do that, the more you start to advance the way you practice every day and every week and every month and every year. The tough part is it does make it harder in ways, right? I mean, right, it makes it harder because you constantly have to be reshaping your systems and reframing your scripting. And you have to be able to have the humility to admit to your previous patients who are like, well, why didn't my kid get that one? A lot of people, I know that's a big sticking point. They're like, well, I've treated all these patients this certain way. And I get it. It can be hard. It can be an obstacle to think, well, they're going to think that I did it wrong for their other child. I found most people, because I went through a big evolution through my couple decades in practice of not having any idea of airway to starting to help people grow, from my perspective, was more just to not have to extract teeth on these kids that had narrow arches and were crowded. And I knew the crowding was, I knew the teeth weren't the etiology. I knew the transverse deficiency was the etiology. So that was kind of the genesis of my expansion journey and early treatment journey, because I certainly didn't learn it at UConn in my residency. So as I went on that journey, I kept questioning and looking at what was happening. And I don't think that gets said enough. Our colleagues, any type of dental colleague, and I would even say our medical colleagues, from knowing and working with a bunch of them in different arenas, there's not enough time spent because we're so busy looking at our outcomes and looking back to where that patient started and really critically evaluating the beginning and the end, or the point A and point B, let's call it. And then looking at that continuum of point A1, A2, A3, A4, kind of looking at this journey they went on. Do you feel like that is a problem in what you see, that people just treat, if it's kind of working, and throw it at the wall, if it sticks most of the time, you can ignore the fact that there might be other things going on, but hey, look, it works. The patient looks good. Or in the restorative world, like that crown fits well, or we can kind of rationalize that what we're doing works and not look deeper, right?
Yeah. And I think, so again, to use like almost a dirty word, holistic dentistry. For me, it doesn't mean necessarily using ozone and removing amalgams and, treating with zirconia implants. So there are plenty of people who do that, and there are plenty of people who want that. For me, holistic dentistry is that exact thing. It's looking deeper, figuring out why. So I have a patient who, every time I close their open bite, it opens back up. Well, why? What is happening? Well, it could be a tongue thrust. It could be a mouth breathing problem. It could be the joints. It could be so many different things, and I want to know what's going on. Same thing as when you're doing general dentistry, you have a patient who's cracking their teeth. So why? Right? Okay, they're grinding. Great, they're grinding, but why? Again, why is this happening?
Yeah.
And I don't think that you reach the pinnacle of knowledge or understanding until you can answer every why for every patient. And that's the biggest thing. There is no cookie cutter answer. And I think that also makes it hard. In terms of efficiency, it's very efficient. Every patient who comes in, you start your 014 wire. This is how you're going to do it. This is my wire sequence. These are my brackets. I always use the same prescription. I always set everything like this, and that's it. My assistants put the wires, and I'm good. I check them. We're out. My practice can't run like that because not everybody's the same. And not everybody got to the point that they're at because of the same problem. Right? There's so many things that can go wrong in growth and development. And unless we're really addressing what went wrong in the first place to create this problem, again, the teeth are not the etiology of the crowding. Why are they crowded? And then once we can address that problem, once we can start to actually figure that out, then I think we can treat.
Yeah. And we're so focused on treating. And that's across the entire spectrum of medicine and dentistry in our country, right? We are so treatment focused that we don't take enough time. And sadly, I think a lot of it is because the money is in treatment, right? The treatment follows reimbursement a lot of times, right? We don't even, in dentistry, we don't even have diagnostic codes. It's only treatment codes. Like there's no such thing as a diagnostic code. There's diagnostic codes in medicine, but in dentistry, it's all treatment codes. So we feel this need to just treat. And to me, when you This is another big obstacle I face. And I actually want to use this to kind of lead into hearing from you how you did and do this, how you incorporate it into your practice and how you implement it every day. One of the biggest challenges I face with my orthodontic colleagues, and even with general practitioners and pediatric dentists, is they're so busy doing and treating that to get them to take extra time in the diagnostic process, more than just look at a 2D pan, look at a 2D Ceph, look at some pictures and say, okay, 18 months, braces, extractions, non-extractions, whatever it is, Invisalign, liners, whatever, you just kind of throw them into that bucket, which may be fine for some patients, right? I say all the time, not every patient's an airway patient, right? Not every patient is this particular type of patient. That's almost what makes it harder, because then you have to figure out which one is and which one isn't. And that takes time. So how did you find the time initially to make that in your schedule? I know you're saying your practice wasn't quite as busy, but you still have to change your approach. And then now that you're getting busy, you're very busy, how do you keep that time carved out of your schedule to do whatever you're doing? And you can go into that too from a diagnostic perspective.
Yeah. All right, let me start with, how do you set that up? I think I'm in an interesting position where I have a lot of ENTs, sleep doctors, pediatricians who actually are referring to me for my opinion on what's going on. And so, yeah, a lot of people are not they don't think the money is in the diagnostics. However, I charge for my time, and I'll tell you what I do and what my intake system looks like. But I want to be able to spend that time. I know what my overhead looks like for that time. And so I charge for it. So I don't do free consultations in my office. A free consultation is take a quick pee. Yeah, your teeth are crowded. Cool.
Yep.
I mean, okay, now what? Now I'm going to treat you the same way as I treat everybody else. I'm going to throw some stuff in your mouth. No, that's not how I want to run my practice. I want to hold my practice to a higher standard. And so I charge for the time that it takes me to diagnose properly.
That's great.
And it's honestly about an hour of my personal time for every single patient. So you'll know what you need to make on an hourly basis. If you're running your practice, charge for your hourly time.
And right there, I want to just interrupt you for 1 second. That automatically, for my orthodontic colleagues, as someone who used to run a very, very busy practice, that seems absolutely impossible to the majority of orthodontists, because we try to get that consultation process down. Most people are happy if they can do it in 2-3 minutes. I'm not exaggerating. That's the goal. That's what consultants are trying to teach is your assistant takes the records, your TC does most of the presentation, which I had both of those things in my practice, and you look at everything real quick, you make the determination, and you've got to get back to the clinic where this is what they say. These aren't my words. I've heard it many times that you got to get back to the clinic, which is where you make your money. And that to me is a fundamental mindset shift that we have to go through in our profession to get to what I call in my interview, which will be coming out. Actually, but when yours airs, Steve Lamberg's will be just preceding it. I was talking about Orthodontics 3.0 and Peter Attia, and he's like, you need to write an article, Orthodontics 3.0. And I think I'm going to run with that a little bit, of the fact that to get to Orthodontics 3.0, we have to spend more of that time on the front end. So sorry to interrupt on that, but I just want to interject that for people listening out there who may not know, for an orthodontist, that almost sounds like that's not even possible.
Yeah, and I think it is a general dental philosophy more coming into orthodontics there, because you can't treat what you don't diagnose, right? That's just the bottom line. And so I want to look at all of it. And this may hit on that second part a little bit more, but when we take our records, I have forms. That's great. The parents will fill them out. But if they're anything like me, I'm clicking note all on everything. I have no time for this conversation. Most likely, I didn't even fill it out until I walked in the door, and now I've got one kid jumping on me, and I don't have time for that, so I'm not going to give you the whole story. So I start with a 10-minute interview with the parents and the kids. During that time, we're talking about everything. I want to know about their birth. I want to know if they were early, they were full term. That has an impact on some guys. I want to know about feeding. I want to know if they were breastfed, if they were bottle fed, if they have a hard time transitioning to solids. I want to know all of these things so I know how the mouth and the oral cavity is actually forming. How are their muscles working? I want to know about behavior. I want to know about what they do for fun. That's going to change some posture stuff. If I have a kid who's like a huge gamer and they're on their phone all day, we're going to have forward head posture issues. That is going to affect the way that things look in the end too. So we'll go through all of their medical issues. I ask a very detailed sleep questionnaire. I want to know what time your kid goes to sleep. I want to know if they stay asleep. I want to know if they've ever gotten up in the middle of the night, walked around. Do they talk? Are they bedwetting? I want to know how they're doing in school. What are their favorite subjects? What are they doing badly at? Because there's some really good data that shows that kids may struggle with math and reading if they're not sleeping well. So are they struggling with anything? How's their peer interaction? All of those different things have a big impact on how the kid is actually thriving and how they're sleeping. So that's the first part. And while we're having this conversation, I'm watching the kids the entire time. Because as a parent, your kid can do no wrong. If I'm watching the kid and they're bouncing off the walls and I'm asking the parent, how's the behavior? And they're telling me it's fine. So now I've got to tread lightly, but I know that there's a problem there if it's not age appropriate. I'm watching any habits that they have. So the number of times that I've finished this conversation with the mom and said, what about that? Well, what about what? Well, I've watched your kid biting their lip the entire time that we're talking. Does this happen at home? Oh, I mean, I guess it does. Okay, so now we know there's something going on that's going to be driving my upper incisors forward and my mandible backwards, right? So every kind of mechanic that I'm using is going to be fighting that no matter what I do. I want to see, are their lips together while I'm talking to them? Do they have a good resting posture, or do I see their tongue sticking through their teeth the entire time? I'm going to be fighting that the whole time too. So that's about 10 minutes that I'm just watching and observing the kid and getting this background history. That's really important. I want to know about supplements, vitamins. So you ask a parent, what kind of medications is your kid on? The answer is none. Okay. What kind of supplements is your kid on? All of a sudden they're on melatonin and they're on like a sleepy vitamin. They're on something to relax them. They're on, all these different things that parents are trying to use because no one wants to medicate a kid. But that tells you there's definitely something going on there. So then I do a functional exam. We're going to look at everything. So obviously I'm going to give them, I tell my assistant, all of the dental stuff. We're going to talk about crowding. We're going to talk about overjet. We'll talk about overbite. We'll talk about the normal stuff. But I'm going to have them close their lips. I'm going to look up their nose and I'm going to make them breathe through their nose. I want to see how their nasal breathing is actually working and can they breathe through their nose. I make them swallow water. I make them chew. I want to look at all of these different things and I want to know, do I need to involve a myofunctional therapist in this treatment plan? Do I need to involve an ENT in this treatment plan? And a lot of the times it's yes. A lot of the times it's no, but a lot of the times it's yes. Then, we take traditional records on everything. So we'll get our pictures. We do take pictures of all of the ties, whether they're there or not. We take pictures of the upper lip, lower lip, buccal areas. We take pictures of the tongue, both tongue up and full palatal suction. We're looking at everything. And I do see a lot of kids, so I may forget these things. And adults, actually. I may forget them by the time I go back, so I want pictures of everything.
Yep.
We take our impressions, and then I take a cone beam. And my rationale in taking a cone beam is, for almost the same exact amount of radiation as a pan and a ceph, I'm going to get about 10 times the information. If I don't think a kid is going to sit still, I'm not going to take the x-ray. But that doesn't mean I'm going to go take a pan and a ceph. I'm actually just going to decline to treat until I feel like the kid is going to be mature enough to handle it. Because if I can't get them to sit in an x-ray for 3 seconds, I'm not going to be able to treat this kid properly.
Yep.
So that's all my intake. So for my total time there, maybe 15, 20 minutes tops, okay? I'm going to spend about 20 to 30 minutes after that. I'm going to look at all of this stuff quietly by myself. That's what my Mondays are for. I'm not talking to you.
Well, thank you for putting me into that.
Nobody comes into my office, period. And I go through all of the kids that I saw that day, and I put together an entire PowerPoint for every single family. And no, I don't think my staff can do it because I'm looking at very specific things. So I will pull up the cone beam. I will pull screenshots. Anything that I see that's obstructing nasal breathing, anything that I see that looks large and bulky, tonsils, adenoids, I'm going to pull up intermolar width on the upper jaw, lower jaw. I'm going to look at where the canines are sitting. And we're pulling screenshots of everything and putting it into this little PowerPoint that now the parents have a story. And when we meet on Zoom, because that's how I actually do what I call a consult, I sit with a parent for another 20 minutes and we're going to talk about everything that I saw. I'm going to show them pictures of their kid. I'm going to show them every single issue that I saw. And then I'm going to show them all of these other things. So you told me that they're snoring quite a bit. I'm going to show you some tonsils here that look really bulky to me. Now, I'm not an ENT, but when I look at this airway and I see that 80% of it is being taken over by these two giant golf balls in the back of their throat, I think that might have something to do with your child snoring. Okay, so now you've got parents who are seeing the problem that it's causing with the face, with the teeth, and they have a reason that some of this is happening. And now they're armed to go and see the proper specialist to help take care of the problem. And we can jump in and we know that the parent's fully informed. I have a true informed consent at that point to do what I need to do with the kid.
And you've motivated them to want to help themselves and help their child, and not just told them, you got to go see the ENT. And by showing them, that's so powerful and so effective. And I've often said that's one of the things I saw in my treatment approach and my acceptance rate of what I was talking about to patients and their parents was once I got a cone beam, which for me, this was early 2014, I was able to do what I call my airway tour, which is essentially what you're talking about as well, just different variation of it. And on that airway tour, it doesn't take anybody to have a medical background or dental background. When you say where there's black, air can go, and where there's gray or white, air can't go, like they don't need to necessarily know all the craniofacial anatomy. And you go up through and you reach those obstructions, right? Whether it be in the nasal passageways or the nasopharynx or the oropharynx or whatever it is, it's very easy for them to see, wait, yeah, there is a problem there. So maybe I do need, because every parent wants to help their child, maybe I should actually take them to the ENT. And my pediatrician kind of mentioned it, or thought I could go to the ENT, but they never really took the time to educate them. And I had Paul Henney on recently, and we were talking a lot about the philosophy from LD Pankey and Bob Barker, and he was talking about the concept of getting to know your patient and getting to know more about them. And as you were speaking, I just kept thinking about that. And it's something I am proud to say I did in my clinical practice was take that time to get to know them. I mean, what you just said, Skye, you're watching them, you're observing things. I love too. I found the same thing you said about the intake forms ahead of time. I would so often, like they'd fill out a sleep questionnaire, or before I used that, my own little house-made sleep questions we would ask. No, like straight line through, right? Nope. And you'd get in and you'd be like, oh, okay. So I see, and you're observing them. You're looking at the cone beam. You're looking at the mouth and the palatal vault, and the kid's mouth is wide open, and there's a problem. And I completely agree. You have to be somewhat delicate with that, because if you come out and start saying, oh my God, Johnny's not nose breathing and he's mouth breathing and he's snoring, and that can affect his gray matter of his brain, and he's going to have, do worse in school. You can become an alarmist and you lose people. Like they're just like, whoa, this person's a lot. And I came to look at his teeth, and now they're talking about snoring and gray matter in the brain. So
we've all done that though, because
not
to interrupt, you start learning these things and you're so excited about it. And you know this, and your brain, your eyes are now open. And all of a sudden, you're seeing these patients that you've been seeing for 15 years, not me, I've only been out for 8, but you've seen them for a long time. And this happened to Blair, my hygienist, when she first started. And now she's talking to everyone about their tongue ties. They're like, what are you talking about? Like, enough, right? But you have to be careful about how you approach it.
Yeah.
Because we lost actually a lot of patients when I first started doing this. And when my father-in-law retired, I think I definitely lost a few families because I brought up my concerns with the parents. And I had one who actually said to me, you're here to look at my kid's teeth. Do not make any more of those comments. And, to that I respond, I'm sorry if I upset you. I'm not here to make you upset. However, as a dentist, my job is to look at the craniofacial structures, the teeth, to look at the jaws, and I'm seeing many things in there that are concerning to me. That's it. You want to be upset. I apologize that I upset you. Let's have this conversation again another time.
And you learned from it, which is credit to you. I mean, you didn't run from it, because a lot of people, when that happens, I mean, I know I lost patients in the beginning when I started this approach, because they would go back to their dentist, sadly, and their pediatric dentist, who would be like, what is he talking about? This isn't a thing. And they were families that I was almost a decade into my practice at this point. it's humbling to all of a sudden have people questioning. I mean, that was at the point where, I don't want this to sound arrogant, but I built my reputation to the point that if I was recommending treatment to someone, there was a very high percentage that they were going to be accepting it and coming to treat with me. And all of a sudden I start talking about this new stuff and I'm losing people. Part of it probably was, as we were talking about, my approach. I wasn't as good at it in the beginning. And I think I was becoming a bit more of an alarmist and pointing out every little thing because I was excited about it, as exactly as you said. And then I learned how to soften my approach and start to take them on that journey to understand that I'm there to help their kiddo and not tell them that there's all these things wrong with their kid, something that obviously no parent wants to be confronted with, thrown in their face. That's a lot. And that comes with time of practicing it, but also you had to take the time to sit there. If you just ran in that room and wanted to highlight as quick, we've all been in, I mean, not to throw it on the physicians, but we've all been to a physician's office where you walk in and all they do is come in for 2 minutes and tell you everything that's wrong and walk out. And they leave a nurse or someone else to come in and try to clean it up. And whether you've had that experience yourself or with a family member that you've taken to a physician's office, that happens. So we've got to be better than that. We have to take the time to look at our patients in greater detail and then ask them those questions, because I would see patients and say to them about the intake, like let's say it was a sleep questionnaire, snoring, no, mouth breathing, no, behavioral issues, no. And then you start talking to them. And as you would ask those questions, I can't tell you how often those things changed as I was talking to them. Or mom and dad are in the room and mom's like, Dad filled that out last night. I told him to go do it. It was 10 o'clock last night. We forgot we had the appointment. Dad went and filled it out and he doesn't know. I mean, I saw stuff like that all the time. So I'm not telling people don't use intake forms, obviously. What I'm saying is you just have to back that up with a clinical discussion and get to know your patient and their family in this case, and let them know that you're not pointing these things out. I'm so glad we got going on this topic because I don't talk about this enough. I kind of just almost assume we do this, but you made me think about the fact that I was not good at this in the beginning either. We have to not assume that they want to know every little thing that's wrong with their child right there, because at the end of the day, these people came to the dentist or orthodontist, whatever the case may be. We know what we know, that we can do so much more. We have to help take them on that journey. Now that you're doing that, how does it work at this point? So we've gone through that process. You explain this to them, and then you start to explain some of the treatment that you can do to help their child, whether it's a referral to a medical colleague or myofunctional therapy, expansion, early treatment. How receptive are they now that you've had a few years of practice to hone your systems and your scripting?
Yeah, I think I get them from two buckets, right? So I get people that are coming into me and they almost think their kids are worse than they are. So that's great. And that's wonderful. They're prepared for all this. They
now
know
that you have
what
the
I
reputation,
do.
you're saying that people know what you do. And a friend
they know
says,
what you
got
do.
it. Okay.
And,
Yep.
and it's great. They're coming in. They want a cone beam on their kid. They've already been to two ENTs and no one will scope their kid.
Yep.
And they know there's a problem and they want the help. That's one bucket. The other bucket is, my friend told me that you fixed your kid's smile. Cool. So, what's going on with your child? Have that whole conversation. They deny any problems whatsoever.
Mm-hmm.
Then you take your cone beam and you look at it and you're like, oh my God, this kid literally can't breathe through their nose. You did your functional exam. They can't breathe through their nose. So I think that the best tool I have is showing. And you said it. It's the more you show, the better off people are going to believe you, right? No one believes you just because you tell them your kid has a problem. You have to show them everything that you see. And I have to say that I think we have a very, very high treatment acceptance rate because of that. I convert a lot of patients from my general practice. I'm always amazed. I had it happen the other day. Someone came in as a general patient of mine and they had a sleep appliance made somewhere else. And I was like, wait, what? That's like half of my practice is this. But
I do that. I know about that.
Wait a second. So it's just, that still happens to me. And I'll go into this story, but I have a mom who wanted me to treat her kids orthodontically, but the dad wanted the orthodontist who he saw to treat his kids. And he very adamant about it. We had been advocating for them to have some kind of an orthodontic consultation for several years now. The child had grade 4 tonsils on exam. She had all the signs of sleep-related breathing disorder. And now we have completely blocked out canines. And finally, they went to the orthodontist. The orthodontist did not take any x-rays. So when she came back for a 6-month cleaning, we, got the permission to take an x-ray, took a cone beam, canines are totally blocked out. I guess the orthodontist was still going to wait longer to do anything. So we sent the pad over and just said, "Hi, somewhat concerned here. Can you let us know what the plan is?" To which I received a phone call from mom that the plan was now to pull the rest of the baby teeth, plan to pull the bis, upper and lower. And she was very concerned about this situation. Dad still would like to see the original orthodontist. And it's hard for me to hear that because I know that we could have done better originally. We could have treated this earlier. We could have made a difference before. We still can make a difference at this point. And so now mom wants me to get on the phone with the orthodontist up the road. And I'm not comfortable with it. I'm not going to do that. I know who my friends are. I know who they're not. And I don't think I'm going to make friends by questioning another orthodontist treatment plan.
Why do you think that is? I was actually going to, believe it or not, I was going to ask you about the interaction between GPs and orthos, because I get caught in the middle on this because I'm an orthodontist and I'm very proud of my orthodontic profession and my education and what I'm able to do as an orthodontist. And I love my profession. That's why I'm so passionate about it. I also try to call balls and strikes on this stuff and realize that there are a lot of my orthodontic colleagues, especially some of the older, more established ones, that will not change their mind. They literally are going to hang up their gloves, so to speak, and say, airway's not a thing. There's no place for orthodontists and orthodontic involvement in airway. And that's all just craziness. Those who are peddling it are quacks and charlatans. And I've been called all those things, so I can speak to that. that is an objection. Actually, just recently, I was telling you before we hopped on, probably within the past 24 hours, I was called a charlatan for talking about airway in an orthodontic group. But anyway, I digress. But for me, it's harder for them to reconcile that because I'm one of them. So, and I say to them, my goal isn't to tell my orthodontic colleagues how they have to treat their patients. My goal is to educate my orthodontic colleagues as to what's possible and what they're missing and what this can do not only for them, meaning it's wonderful when you're helping patients thrive in a different way. I mean, straight teeth are great and it's awesome making great smiles. It's a whole nother level of awesome when you help a child breathe that is suffocating, even if you just catch the issue and refer it to your medical colleague at the minimum. But there's so much more than that we can do. But that's really what I'm trying for. And I also speak up so loudly on this, and I focus most of my energy now on teaching my younger colleagues, residents, young docs, because they haven't had the time to be out there and doing it one way for so long. So they don't have to worry about changing their whole approach and realizing that they did things maybe not ideally for a while, but that's okay. They can grow from that. They just can go all in on a new approach, and they are so receptive to it. I lecture to so many residencies. It's wonderful. I mean, a lot of times these residents reach out to me and they're like, hey, could you come talk to us about this? So that's the really encouraging part. And that's why I'm so passionate, and that's why I'm not giving up on my orthodontic colleagues, because when I teach a resident at Nova, we have numerous examples I could cite of where I teach them all this in the didactic sense in the lectures. And then when they see this play out in the clinic in front of them, Skye, their faces, like, they just freeze almost. They're like, oh my God, this is like exactly what you told us was going to happen, that the ENT is going to say there's no problem and won't scope them. And, they went to an outside practitioner who said there's nothing to see here and wants to pull teeth. And so I'm encouraged by that. So back to the question I was saying is, with me, it's a little different because I'm an orthodontist, and an orthodontist can just call me a quack or a charlatan, but they can't say, good general dentist, right? You have no place in this orthodontic arena. General practitioners who are doing this face that. You have to deal with that. How do you deal with that? Because that's hard. That's not easy to have your colleagues saying those things and telling you have no place in this arena.
Yeah. When I decided to be a general dentist, I would do in my office whatever I could do as well as a specialist. And so I have had, especially when I first started doing this, several conversations with orthodontists where they started pretty aggressive. What do you think you're doing? And for me, I wanted to have that background so that I could answer that question intelligently and almost disarm them with my knowledge base, right? So I think when someone comes at you hot like that, they're expecting you to back off and have no idea what you're doing. Right? Or answer it like, they can't breathe, so I have to expand them. Right? That's not how I'm going to answer that question. I had this conversation with a gentleman who now, is very cordial with me, and I send him patients when I don't feel like it's the right fit here. And I've actually had some of the orthodontists around send me patients when they feel like I'm a better fit.
Which is awesome.
But I'm going to tell them exactly what I'm doing and why. this is my diagnostic approach. And just to go back into this is why I think it's really important to get that training early. And a lot of those very basic orthodontic principles, I didn't get through different airway groups. I got them through International Association of Orthodontics. And I'm teaching with them now because I think it's so important that if you're going to be a GP doing ortho, that you better be able to read a CEF properly, because what if someone asks you a question about that? I mean, that should be part of your diagnostic procedure anyway, right? Yep. You should know all of the angles and what they mean and why you're looking at them.
Yep.
You should know what their growth potential is and what does that mean in terms of the mechanics you're going to use. You need to know the basics of orthodontics to do orthodontics as a GP, period.
Yep.
And so I answered it the way I figured an orthodontist would want me to answer that question. I went through my CEF tracing with him. I went through all of my findings. I didn't even talk about airway first, just talked about it strictly from an orthodontic perspective. And then I mentioned, so how I see it, there's probably 2 different ways I could treat this case. I went over both different ways and told him why I chose to do it with an expansive approach instead. And then I mentioned airway, finally, very last. Said, and it turns out this kid has sleep apnea, just had his tonsils and adenoids out. And so I'm pretty happy that I didn't decide to shrink his airway a little bit more or limit his tongue space. I always choose to talk about it as tongue space, just to not make anybody angry. So, and like I said, that ended up being a really positive conversation. We talked a lot about muscle function because the kid had a serious mentalis activation all the time. And it was really driving the lower incisors back and causing all of these problems that were more myofunctional and needed to be addressed as well. And yeah, I think it's hard to have a negative interaction if you're armed with all the information.
So true. It's so true. And it's because that's instantly disarming. Because I mean this when I say this, Skye, you know more and have done more research in the airway arena than most orthodontists have. It's just a fact. It's not a criticism of my orthodontic colleagues at all. It's a fact. We don't get this in our orthodontic residencies to that extent. You did 200 hours of CE in sleep medicine and airway during the COVID shutdown. Most orthodontists haven't done 200 hours of CE in anything related to airway in their entire careers. So that's one of the things I actually say to a lot of my orthodontic colleagues is, if you want, I'll hop on a call. I'll try to teach you some of what I've learned in the research and the data. I've put it all out there on podcasts and on YouTube and a lot of free content as well, tons of free content to try to educate people. But at the end of the day, people don't want to take the time to sort through all that and try to go learn it. They want it spoon fed to them. So instead of trying to post a lot of stuff on random Facebook groups, which it can be just futile a lot of times, I'll just say, hey, look, I'll hop on a call with you for an hour if you want on a Zoom call, and I'll just take you through some of these cases and show you what I'm seeing. Sadly, no one ever takes me up on that. They tend to just kind of call it, they don't want to know. They don't want to know. And that's when I know I'm dealing with somebody who never going to change their mind, and I'm better focusing my efforts on someone who really wants to learn. But that knowledge is so essential. And I guess it's kind of the definition of ignorance, right? I mean, if people want to stay ignorant and willfully blind on something and stick their head in the proverbial sand and say it's nothing, kind of, fingers in your ears, stop talking about this stuff, then they're going to do that and find any reason to justify those actions. So when you disarm them with knowledge, it's great to see that some of those colleagues are responding to say, hey, wait, there's something here. And I think the reason that you and I both have to do that, coming at it even from different perspectives as an ortho and a GP, is there are people, both orthos and GP, who overdo it. And that's where I said I get caught in the middle, because then people are like, well, you're the airway guy. I'm like, no. I'm about treating my patient and helping my patient be healthy. And sometimes that ties into airway, and I have to be prepared for that and know what to do. But I know people who every patient who walks in the door, whether it's GP or ortho, they're expanding every case. They almost take the cookie cutter approach we were talking about in the beginning, right? That orthos take. They just do the same thing, except they do it on the 180 degrees on the opposite, and everybody's starting early and everybody gets an expander when they walk in the door. And that hurts our credibility too, because
absolutely,
right? The common thread is neither of those two extremes are doing the diagnostic work that you highlighted that I agree with you is so fundamentally important.
Yeah, I had 3 kids last week that I actually told the parents, you don't need me. I don't know what to tell you, but you don't need me. I'm not going to do anything. And there's actually kids who are airway issues, and that's really the younger ones when they're in that 2, 3, 4 range where they're airway issues. But I always tell the parents, I'm not the main player in this case. Like, I'm not going to be the one who solves this problem for you. But there are other people who will solve this problem for you, and I think you should go see them. And why don't you come back to me in a couple of years, or even you want me to take a look in 6 months, you can look in 6 months. I don't care. I'm not going to charge you again. Just pop in. That's going to be a quick look because I want to see if things have changed and where we're at. And then maybe it is time to treat a kid if we're still having issues with growth and development after everything else has happened. But I try to break down every case for my parents with what's the biggest bang for your buck? Because it's time, it's money, and it's effort. And all of those things are limited. And so if I'm going to have the biggest impact, if me expanding the arches is going to have the biggest impact on that kid, then I'm happy to jump in. That's where I thrive. I love doing that. If the ENT is going to have the biggest impact, let them go. Let them do their thing. Please, please. And go armed with all the information I'm giving you right now and take it to the ENT and let them run with it. If the myofunctional therapist and that tongue tie release is the problem, then go there. Please go there. I don't need to be involved in every case.
That's so great. You have such a pragmatic approach to it. And that's what I really wish more of our colleagues, regardless of whether they're an orthodontist, GP, pediatric dentist, would just take that practical approach of exactly what you just said is once I do the diagnostics, I then know who this patient is best suited to see and where they're going to get the best bang for their buck, as you said, and most help for their child. And sometimes I'm part of that. Sometimes I'm not. And I'm okay with either because my goal is to find that out. And I actually really like what you said about charging for your time for diagnostics. And what's happened in orthodontics is because of competition, they don't charge for that new patient exam, that consultation up front, because if mom or dad are calling 3 offices, and most people do get 2 or 3 opinions nowadays, and one of them tells them they're going to owe them a few $100 even up front for something like this, they're not even going to come into that office. It's just unfortunately the way we've done it to ourselves, because this is like the way it's been in ortho. The way I did it, and I'll just put this out there for my ortho colleagues, maybe this could help some people, is I did charge for that, but only if they started treatment with me. So what I did is I didn't charge it up front, but we had a records fee and we charged for the cone beam and for the pictures and for the consultation. And those were all line item fees that were billed, but we had in our scripting when they called, there was no upfront fee due. And if they never started treatment with us, or if we put them on observation, we didn't charge them for that. I ate the cost of it. But for the people that needed treatment, we then rolled that into their financing for their entire ortho fee. So let's just say it was $500. Then the treatment fee would have an additional $500, still itemized line item, is that was the records. We didn't just, ignore the codes of what we did. And then if they started, then they could finance that as part of their treatment financing that they would do over the duration. And so that was nice. People didn't have to come up with $500 right off the rip out of their pocket, because I wasn't a par provider with any insurance companies at any point in my career. So it would have been directly out of their pocket. And it also helped me financially cover my expenses of spending this extra time with them, and the investment in my cone beam and the investment in my records process and in my diagnostic process and my scripting of all my team members to educate them on this so they can educate the parents and patients. So that's just a little way for the orthodontists out there who are hesitant to charge for, or even a general dentist or pediatric dentist who's hesitant, you could take that approach. I ask this a lot of my guests, and I apologize to the audience if they're tired of hearing me ask this question, but I get asked it so much that I just want to hear different people's thoughts on it, because it is very different based on the regions you're in. I personally happen to know the NT that you work with. I was connected to him. He's amazing. Not everybody has that. And I struggle with people who reach out to me. I have laypersons, parents, plus colleagues who reach out to me all the time and say, I've got this patient. I took a cone beam, their adenoids are obstructive, or the nasal passageways, or whatever the case might be, big tonsils, the case you were talking about before, right? Yep. And the ENT won't do anything with them. They won't scope them. They won't touch them. We sent the image and they're like, nope, they'll outgrow it. It's really frustrating for parents, and the time and money to go to 2-3 different ENTs, take a day off of work or a half day off of work, kids out of school. When we, it sounds simple just to say, well, then keep finding someone. I'm not saying that's what you're saying, but we could be kind of callous as providers and be like, you just have to keep finding. And I don't disagree with like that concept, but the implementation of that is brutal on these patients and their families. So what would be your advice to some providers out there if they don't have an oral malfunctional therapist nearby, or an ENT who understands this, or an allergist who sees kids and understands this? Like, what do they do?
Yeah. So Dr. Raval is who we're both talking about. He's just absolutely incredible.
Yep. Amazing.
But when I first started doing this, I didn't have him as a resource the way I do now. And the way that relationship kind of grew was because I had 4 or 5 kids at once that I knew needed to go see ENTs. I had no ENTs in the area that I knew were good or wanted to talk to me or anything. And so I figured I would send each of those kids to a different ENT. And so I sent all 4 up. They saw 4 different ENTs. And I followed that up after I knew they had their appointment. I followed it up with a phone call to their office. And I just said, hey, I sent over a patient. I would just love a chance to have a conversation with the doctor about that patient and see, what they thought. And I got phone calls back from 2 of them. One who was not like a pediatric specific ENT. And I wanted to talk a little bit about all of this stuff. And it was a shorter conversation. It was around 5 minutes. If tonsils are big and bulky and they have sleep apnea, I'll take them out. I was like, okay, so are we doing sleep studies then on every single kid? He's like, yeah, I'm not going to take tonsils out without a sleep study. Okay, well, I don't know necessarily that our approaches are going to mesh. So we're good.
Yep.
Thank you for your time. And then I had Dr. Raval. And again, this was right after COVID. And he's like, yeah, you want to go have lunch? Like, well, let's go sit outside somewhere. And we went and sat, and I brought my Healthy Start PowerPoint that I had. And I'm talking to him about, airway and how the kids' faces are growing and all. And he's listening. And, he ended it with like, so what can I do for you? And I said, look, I want to send kids to somewhere that's going to take the time to look at them, that's going to take the time to understand the perspective that I have, which is not just how many cases of strep throat did this kid have this year. It's how is their ability to breathe affecting the way that they're growing? And then how is that on a long-term perspective, because I see these adults, how is that going to affect them as an adult with their breathing, their sleeping, and their overall health and their whole body inflammation? And it's been great to work with someone who can look at it from multiple different perspectives.
Yeah.
That doesn't mean I send them to him and I say, Dr. R is going to take your tonsils out. Never.
Agreed.
I never say
Thank you for saying that. Agreed. Yep.
Never. I say, look, I'm looking at some stuff here. These look a little bulky. It looks like there's a little bit of a narrowed airway space. And every time I look at a structure that is not the mouth, directly the mouth, I will say I am not an ENT.
Yes.
I will qualify that, and I will say I'm not an ENT, but I have an awesome ENT that I love to work with, and I would love to take a look at your kid if you're okay with that.
Yeah. Yeah, I love that scripting. I'm so glad you said that. It literally is what I used to say all the time to people. I'm not the ENT. I'm not the allergist, but I can detect when there's abnormalities in those areas and refer them to the experts to tell you whether or not Johnny needs something done with that, right? And so I guess the message would be, try a couple different ENTs, try to find somebody with different patients. I just had this happen in the residency. I did preempt mom that I prepared her for the fact that when she went to the ENT, they may tell her, this is nothing. Even though mom clearly saw the 3D and the obstruction and knows her child has significant behavioral issues and is suffocating every night. He's on ADHD medication. You may go to the ENT and they may say these 75% obstructive adenoids, they're not going to do anything with them. And in this particular case, he ordered a sleep study, just as you said, and sleep study came back. Lo and behold, normal, fine, right? Kid was fine. Mom has videos of him suffocating at night. Sleep study comes back fine. And I told this in Airway Conversations that I'm doing with Nicole Goldfarb, where we're just talking about a lot of this stuff. But for anyone who didn't hear that, mom proceeds to tell me that they woke him up at 4 a.m. to stop the study. So if we want to know maybe why that wasn't going to show anything, again, we don't have to dive too deep into that today, but the sleep ap industry, there's not standardization and you don't always get reliable results in children with these sleep studies. So mom was prepared for it, but boy, is it exhausting and deflating to the parent. They come back and they're like, I took the time off of work. I took him out of school and I need a new ENT, And so I guess I would just say to our colleagues, it's hard, and just be supportive of the parents, right? And let them know this is a journey and not everybody's aware of this yet. But the interesting part, Skye, is because myself and the resident had educated mom about this ahead of time, going back to that point, right? She was the advocate. She literally said, I walked out of there and I said, we're going to find another ENT because I know there's a problem and I want someone who's going to look at my child and not say, just wait, my child needs help. So, we're doing some expansion. So we're doing our part, but he needs an expert in otolaryngology to look at that area. And I would think probably do something. So anyway, so that's a really, really good point.
I would also, sorry,
please.
I just want to add on that. If you are sending to a brand new ENT, I find one of the best things that I can do is provide screenshots from my cone beam. Right. So they may not want to scope a kid that they don't know, that's not necessarily behaving, that's whatever. So if I can provide some screenshots, and I wouldn't say like, I think you need to take the adenoids out because look at these adenoids.
Right.
But I will say like, enlarged adenoids, question mark, because I'm not an ENT. So I'll put that in there. And then I'll put all of the symptoms too that we talked about. We've got nocturnal bruxism, we've got bedwetting, we've got attention issues. We've got all of these other things. Mom has noticed snoring. The child's in their bed every single night because they may not have the time that I just took to go through that whole process and ask all of those questions. But I want them bullet pointed out there so that when the ENT is looking, they've got all the information I took the time to gather. And now maybe they're going to take me a little bit more seriously.
That's such a great point, to make sure you do that. And that's something I did in practice that I'm not doing a good enough job in the residency, because as part of the hospital system, the referral system's kind of weird. Yeah. So you saying that is just kind of awakened me to say, no, maybe one of the things we need to do is make our referral letters more like they were in my practice so that we can get that information in front of them. Because just like we talked about educating the parents, once you educate them, it's hard for them to deny the existence of a problem. As you said, you're not telling the ENT, take the adenoids out, but you're saying there's a lot going on with this kiddo that you probably aren't going to take the time. You're not saying this part, but it's essentially, we know the ENTs, very few of them are going to take that amount of time and do the diagnostic workup that you just did, right? So if you can help them and give them the information that you just obtained, then maybe that ENT starts to say, there's more that can happen here. So before we get to the last question, one of the things I'm trying to get across to our listeners, because I find that this is a question I also get a lot, is how to start doing this. So you went on this journey pretty recently. You explained a lot about your educational process and learning. So they've done that, right? They've gotten the education. They're starting to know more about this, but they are in, say, a busy practice, or they work for a corporate, or they're, whether this is, doesn't matter, specialist, generalist, their senior doc or docs aren't in on this, right? I hear that a lot. But the doc that I'm speaking about, they do believe in this. They think there's something to this. They want to start helping patients in this way. Anything you could offer to those people, and maybe some strategies they could use to start to do some of this with their patients, even if the system that they're working in is not conducive to it?
Yeah, I would say, how much time can you afford in the system that you're in to do the proper diagnosis? That's the first thing. The diagnostic part of it's going to be the biggest part for me. And so if you have that education and you have all the knowledge there to be able to do it, then if you're not doing it, you're doing your patients a disservice. And I think just sending, even if you just allocate an extra 5 minutes, what's 5 minutes of your time per patient? That's not a lot.
Right.
5 minutes, take the extra 5 minutes per patient. And then you'll see how that starts to snowball into a little bit more. And I don't think it's not always the most scalable approach. So I don't see 100 patients a day.
Yeah, it's good to say that. You're right.
It's not. You have to make a choice. And it's the same thing that I think a lot of GPs are facing right now. Are you going to be the Aspen Dental and just do all of everything very quickly and whatever? Or are you going to be the high-end, the well-trained practitioner that you want to be and provide the care in the manner that you want? And so I'm not telling everyone to go quit their jobs and go start their own practice, but if you start doing this and you have a passion for it and you love seeing how it impacts your patients, then you have to put yourself in a situation where you feel comfortable with the treatment that you're providing. I know, like you said, I've definitely been called names, but I sleep really well every night.
Same.
I know that every day I do everything I can for my patients. I put everything I can into that while I'm at work every day. And even after, every one of my patients has my cell phone number because I care. I truly do about every single one of those patients. And I want to make sure that that their child, that they're all doing well. But that's not the Aspen Dental approach.
Yeah, and that's okay. Like you said, there's different approaches to this, just like in any industry, in any business, there's different lines that people have to choose to walk, and it gets into their vision for themselves and what they want to do and find the most fulfilling. And as far as the name calling, take it as a bit of a compliment, because I find that when you're over the target and when you're saying things that are on and make people uncomfortable, but not saying it intending to make them uncomfortable, just saying it because of what you believe and understand, and people attack you for that, typically it means you're onto something. Because they feel somewhat threatened to attack you on a personal level, meaning if they're throwing arrows and hurling personal attacks, like you can question me on what I'm doing. We can have an educational debate, but when people get personal and start attacking you for it, there's a pretty good chance that you've struck a nerve for another reason. So you're doing a lot right. So just to wind up, speaking of doing a lot right, how do you balance it all? Being a mom, a wife, a practice owner, a busy practitioner, a lecturer, a student still, you're constantly learning and seeking additional education. How do you do it? How do you have time? What would be some of your advice to people out there because this is, it's something a lot of people I know are struggling with, how to fit it all in and be good at everything. And it's not easy. And I'm not meaning to imply that you don't have any challenges out there as well, but how are you keeping all those puzzle pieces together?
It's so funny because I had 2 people last week tell me that apparently my 24-hour clock is completely different than theirs, because tell me everything I do. And it was like the same day. One was my assistant, Mari, and she's like, I just don't think we have the same clock. And I went to physical therapy, and my physical therapist was like, how hours are in your 24 hours? Like, go to bed every night at 9 o'clock. I wake up at 5 in the morning. I have an hour to myself before my kids wake up. They're in school. They're a little bit more independent. I work 4 full days a week. So we work 36 clinical hours a week. I use my Monday to deal with paperwork because I do own the business part of it too. So that's my business time. That's my treatment planning time. I do my consultation. Those Zoom calls are during lunch. So while I talk to my patients, I have no problems doing that. It doesn't bother me. And then I have an awesome group of people around me. So my husband and my parents and his parents help a lot with all of the carpooling after school. But I make sure that my weekends are with my kids. They're getting old fast, as we were talking about.
Yep, it happens fast.
You don't have one. You don't have them forever. So it has definitely changed the way I take continuing education now that they're getting a little older, now that I don't want to miss their baseball games on the weekends or their soccer games, or I want to go skiing with them when I can. I do a lot more online. I do a lot more reading of articles by myself. And the lecturing that I'm doing for IAO, we've actually changed a lot of that to be Zoom calls now at night with the groups. So we're doing a lot more online education for that too. And like we were saying, when they go to college, I'll have all the time in the world to go wherever I want to go. But right now they are my priority. And my patients have been very, very respectful of that. I don't get phone calls randomly on the weekends unless they're required. And I'll go in because I know at this point, any patient who's calling me on the weekend really needs me. But yeah, I think it's a lot of compartmentalizing. And I've always been somebody who likes to be busy. So it worked out.
Yeah. Well, thank you for explaining that. And it is hard. It's great to hear, though, that you're still getting sleep, that you're spending family time, that you're prioritizing all of these things and keeping all of those. Trevor Nichols on, who's a great orthodontist a little while back. And we were talking about those are all spinning plates. Like each one of those is a spinning plate, and you've got to kind of keep it spinning without it, going fast enough that it doesn't fall off. And for us type A's, A pluses, so to speak, we don't want plates that aren't spinning. We like that. That fuels us. It's our energy. But sometimes they can get spinning so fast that they can also fall, right? If they go too fast. So I love that you're intentional about your time and your time management, and you have boundaries. You've set boundaries. These are my clinical days. This is my family time. This is my bedtime, right? I think that's a great lesson that so many of us can learn, that it's set those boundaries, because if you don't set them, no one else will.
Absolutely. And I think that was one of the biggest things when I took over the practice. My father-in-law lived literally next door. So half of my practice is a home. And
Yep.
We wanted to come see him on a weekend. He had no problem with it. He would walk next door. And I would get phone calls for the silliest things all night on Friday night, on Saturday. And, I'm 20 minutes from the office. I'm just not going to do that. So we started setting those boundaries early. And even Friday afternoons, I pick up my kids, which means I am out of the office at 3 p.m. We start at 7, we're done at 3. I'm in my car at 3 o'clock, or else they are being left there. And my patients know that at this point. So it's 2:59. I'm like, they'll check you out up front. I'm out. Bye. And I'm out.
Yeah.
So I think boundaries, especially and I don't mean to like gender stereotype, but I think as women, we have a harder time doing that because we're always there for everyone. And we do have to set those boundaries because it'll burn you out so fast that you won't be around to help everybody.
And I see it all the time. Yeah. And it's something that people come to me a lot with. So thank you for talking about that and explaining that, because that is a problem for a lot of people. They get doing all this and it just gets to be too much, and then they don't even enjoy any of it. So it's clear that you're enjoying the ride as well, which is something I'm a big believer in, is doing what fulfills you and makes those around you better, and enjoy the ride and enjoy what you're going through, because it goes fast. And I'm telling you, as your kiddos are 11 now, you were saying? Yeah. So as having one who's almost 19 and just about to turn 16, man, does it go fast. And we were talking before we hopped on with my older one. She's about, heading towards the end of her first year at UF. My little one, who's now a sophomore, it's not too many more basketball seasons and lacrosse seasons, right? I mean, it's the chaos and the travel, and all of a sudden, there's going to be a hard stop in 2 years. So I really
Live is City all at the same time. So
that's right. Yes. Oh my gosh. Yeah, you're going to have with the twins.
Try to enjoy it while you can.
You do. And for younger parents out there, set those boundaries now. Set them now. And if family time and being with your kids is a priority, prioritize it, because I know it seems crazy and busy and hard, and that it's always going to be like that. But now that I'm on the other side, I can tell you it's not. So some of the best memories you're going to have are going to be those times that you spent with your children and your families, much more than that particular one extra patient you saw at 3 o'clock if you sat a patient instead of going and getting your kids at school, right?
Yeah, exactly.
So, well, thank you so much, Skye. You're awesome, and really going into that much detail and personal detail and talking about your practice and the intricacies of what you do. I really appreciate, and your openness, your honesty, and your journey, the journey you've been on, this quest to do better for your patients and for our profession as a whole. So thank you for that. I really, really do appreciate it. Any way people can get in touch with you, or people want to follow you online, on socials, anything, I can put it in the show notes too. But if you're speaking anywhere soon or anything you want to talk about that's going on with you.
Yeah, I mean, I'll put a huge plug in for, again, International Association of Orthodontics, the New England chapter. I lecture for them. And if you want to follow our Facebook and our Instagram, it's pretty weak right now, but hopefully it'll be getting better, at Dental Sleep CT. So.
Okay, and I can relate to that. This year has been a goal of mine, upping my Instagram game a little bit. I'm getting there slowly. I'm certainly not where I need to be. But
that's one more fire. That's a full-time job too.
Yeah,
so.
Yeah, that's a plate in and of itself, is the social media side of things. Yeah, but well, thank you so much for being generous with your time and explaining all of this to everybody. I know it's going to help a lot of people out. And if you're out there hearing this and you know someone who could benefit from this too, share it. Pass it along. Share it with people. Skye's message is really powerful and amazing. So thanks so much again for coming on.
Thanks again.
All right, bye.
Bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses, or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.